Section 6E is going to be syncope. We're not going to go through this whole section and read it because it is very similar to the last several sections that I've read and that you guys have listened to. So I'm sure you don't want to hear me repeat myself even more than I already have. The big thing with your syncope patients is, first off, what is syncope? That's when a patient, passes out or doesn't remember what happened. If they don't know if they passed out, just always assume that they did and treat it that way. Your big thing with syncope is getting your vital signs and your cardiac monitor on and seeing what their initial set of vital signs are. Did they have a syncopal episode because they're hypotensive or because of their cardiac rhythm? And if those are the cases, then we've already been over the protocols on how to treat those patients. Your blood glucose, if their blood glucose is low, we've been over how to treat that type of patient. Just any reason why they could have a syncopal episode and treating per that applicable protocol. I looked over this before we started, and there's nothing in here that we haven't talked about in the last 3 videos. So it's very, very, very simple. It talks about your blood sugar and your narcotic overdoses, and then for paramedics if you need to intubate the patient with medication. If the very bottom it says consult online medical control if uncertain of etiology and treatment plan of altered mental status. Never be afraid to call and tell Dr. Knowles, Dr. Goodlow, sorry, I could not think of, or Howerton, or any of your supervisors, anyone, and tell them what you've got and you cannot figure out why this is going on. There's nothing wrong with that if you can't figure it out. So that's pretty much all on that. Since this was a really short one, we're going to go ahead and jump into this dystonic reactions because it's another very short one. This is section 6F. The treatment priorities on this are just vital signs, O2, dextrose for hypoglycemia, benzodiazepine for active seizures, and then evaluate differential diagnosis of altered mental status and treat per protocol. Nothing different, again, in the EMR EMT box. Nothing different for the intermediate advanced. It's all going to be the same as our altered mental status protocol and what we just talked about. The only difference is going to be down here for the paramedic level, which is going to be for dystonic reactions. We can give Benadryl, diphenhydramine, which is 50 milligrams IM or IV push. For pediatrics, your dose is going to be 1 milligram per kilogram, max of 50. Remember, a little trick I've mentioned a couple times, your max is always going to be, your max for a pediatric dose is always going to be your initial dose for adults. And if you don't know your pediatric dose or math is hard for some of us, just use your hand heavy. You can use your hand heavy for an adult if you want to. It actually helps out quite a bit sometimes too. If no improvement 15 minutes after your Benadryl administration and marked muscle spasm tone, then we can give midazolam, Versed, 2.5 milligrams IV IM IN, or diazepam or lorazepam, as we talked about. Your diazepam is going to be 5 milligrams, lorazepam is 2 milligrams. For pediatric, it's the same thing as what we talked about with seizures earlier for pediatric seizures. Continuous assessment and treatment of suspected etiology per applicable protocols. Consult online medical control if above treatment is ineffective. And that is a wrap for section 6. Nice and short. All of it kind of ties together. So if I skip something and you have a question, again, feel free to reach out. Talk to me or Jake or one of your supervisors, station officer, whoever that is.